What Michael asked me to do today, and I'm pleased to do, because it was an interesting exercise for me. I'm very norms versed, but it helped me to become more Pallium versed with regards to the norms, is to take a look at how Pallium fits with the norms of practice. So that's what I'll take you through. First of all, I do want to talk about the norms. For those of you that don't know what they are, we're pretty excited about them. For those of you who do know what they are, you're pretty bored with them, I'm sure. But it's been a long process that we've gone through to come to what we have, and I think it's important just to have a little idea about what that's been. And then, yes, as I said, how Pallium fits with the ideas embodied in the CHPCA norms, because I think that's really important. We all, when we went through the process of the norms, we said we would all try in Canada to try to take any of the work we did post-norms to try to measure up with them. So, in 1989, this is a very long time ago, this predates my interest in palliative care actually. It started in BC, and it started in metropolitan Toronto at the same time, this dialogue about what is it that informs our practice. And we really felt that we had nothing consistent that said these are the standards we'd like to really use to measure our practice against, and this would be a valuable thing if we could somehow do it. But very quickly realized that it was a large project, so the Canadian Hospice Palliative Care Association, and I put it in there as such, but it was then just called the Canadian Palliative Care Association, if you want to get into language problems. They said, we'll consolidate it, we'll be the leaders, we'll help. And I put norms of practice there in brackets because we didn't call them norms to start off with, because we learned an awful lot about what people thought about standards as we went through the process as well. So in '93 then, we decided that in order to do that in our country, particularly, we would have a consensus building process. And this really was validated mid-process, I have to say, when we brought in who was then the chair for the National Hospice Organization in the States, and looked at what they were doing to come to terms with standards in their country, and they were doing what they tend to do in America, was bring together experts and create a standard and then tell the masses what that standard would be. And we laughed ourselves silly because we said if we tried to do that in Canada, we'd cut off at the knees. This is not how Canadians do it. They want to debate, they want to talk about it, they want to input, they want to revise, and so we went through the exhaustive consensus building process that we knew would be necessary in order to come to something that people would actually use, because we knew that people would have to build it before they would use it.
And you like this afternoon?
Yes, exactly. So first of all, there was a consensus committee, and this is probably people in this room who were on it. I sure wasn't. And they came from across Canada, from 14 members, so it wasn't necessarily tied to the provinces and territories. They reviewed the literature from Australia, New Zealand, Canada, UK. IWG is the International Working Group on Death and Dying, and the United States. And they published the first draft standards, which a lot of us, I think, founded programs and services on before we came to consensus, and that's called Towards Consensus. And what that document did in the first place was to determine some of the standards that could be articulated. Then we did send this out far and wide, and within our working group we decided that if we were going towards the next piece of building consensus, we had to have some threshold, and we said we'd be satisfied with 75%, which is actually pretty high when you think of what you look at in some research activities, but we felt that to truly say we reflected consensus, we'd have to have that. So in the years of 78 to 79, there were 17 workshops across Canada. And the idea was to collect the feedback, and they were done in a workshop format. There were pros and cons that we critiqued about that afterwards, because what we found out was there was a lot of kind of groupthink going on, and that we'd get lots of after comments about, well, they really wanted to say this, but the persuasion of the group was that, no, that wasn't a good thing to say. But we did get some qualitative data and some written submissions, and so we knew that we could triangulate with that and know that we had some accuracy. And then we published results again in How Close Are We to Consensus. And a lot of people didn't see that document, but it was something that we felt we had to put out there responsibly to say, we're working on it, this is the direction we're going in, we are getting somewhere, because it turned out to be a 10-year project, and people get tired and back away from and get bored with, and we thought we'd try to keep them engaged with this. You can't imagine how difficult it is to try to keep the people on board with something this long. So then we collated all our feedback, and we did a new literature search because we knew that evidence was moving along, and then we came up with the proposed norms of practice. And those sat with us for a while, and then we decided what we'd do is do an internet-based consultation, so removing that groupthink from it, using the technology that we had, using the resources of Growth House because we didn't have any money, and so we had it coordinated through their engine, and we collected feedback then on 99 items. We had 419 participants, this many Likert responses, and written comments on it. People were asked, yeah, it was really pretty huge, and thank heavens we had it on an engine because we couldn't have done the same kind of exhaustive analysis we did in the first go around. But people were asked not did they agree with, but could they live with? And it was a really important part of the process of not asking people, was this accurate, did it reflect what they thought, but could they live with? And we were able to say, when we synthesized it, that we had a model that we could publish, that it did come to a place of consensus, that it actually gave us guidelines that were very important. So that's how we got there, and this is what it looks like. And the thing that we started with was looking at the illness and bereavement experience of patients and families, and the multiple issues, the domains we would describe are the issues that they have. We came up with a definition of hospice palliative care. It was fairly simplistic because we'd had very long and then this and also that and don't forget this, and it just, people got lost in it. And actually the piece that was of greatest difficulty to gain consensus on was the definition. So, but we were able to come out then forward with values, principles, and foundational concepts which guided patient and family care. And also what we brought into the second model then was the notion of guiding organizational development and function, because people had said through the first model, it's great, it's really clinical, it misses the notion that there needs to be some guide for program development. So norms, and we moved from standards to norms because people, when we said it a standard, there was a lot of, I don't want to be measured like that. I don't want to be held accountable to something, particularly when you're trying to articulate a high standard, that people are going to say you're falling short of the standard and you're substandard and you're not fundable and these kinds of things. So we went to normative practice, which is the usual or average. So we weren't looking for creating that gap for a lot of providers. We used a normative statement then for each issue or more. We know they were less specific than standards. They did gain acceptance, and they do guide practice. So the notion with a norm, though, it isn't just sort of the usual or average. It does suggest where we're striving and where we're going to. So again, it doesn't let go of the idea we could be better. It does empower activities, and that is particularly in these areas, which has relevance. And the relevance for Pallium then, particularly in capacity building, the curriculum development, the funding, the legislation, advocacy, and the benchmarking and accreditation, but I didn't put it directly because I think that's more of an indirect function. And as I say, this is my learning and trying to put it together, so correct me if I'm dead wrong. The principles then is it's patient and family focused, high quality, safe and effective, accessible, adequately resourced, collaborative, knowledge-based, advocacy-based, research-based. So those are the principles that the norms are based upon, and these are all the principles then that I see as guiding Pallium as a project. The foundational concepts then, I believe Pallium does embody them, and these are that it's about effective communication, it's about effective group functioning, and it's about the ability to promote and to manage change. So it isn't just about invoking change, but changing us to change managers ourselves. This is then how we looked at the possibility of the scope of activities that norms could be used for. Really, in the very beginning, we thought it was this, the clinical care and the capacity building. But it did move into the whole notion of curricula and exams, of the outcomes, and some of the benchmarking then and accreditation and licensure standards. Funding, if you could say you're operating according to some accepted national norm to a funder, you've got a much better chance of actually getting funding, particularly in the private domain. Legislation, you know, in time when we look at our some of our credentialing that we're looking at, and then public relations and advocacy strategy. And research is the basis on which it sits, and we really understood that without, you know, we're working in a young area in terms of a discipline, and without the science to drive it, we're really sort of mucking around in the dark here. So without that base, we're at a bit of a loss. Here's Pallium. So I've kept you out of legislation, but you know, I think, and you know, in the end, as an ultimate goal, that's where you'll go.
You've kept us now.
Yes, that's true. You're right. I'm not there yet. So then we talked about a change process that worked for individuals, and that we were looking at a combination of things in terms of attitudes, knowledge, skills, behavior that would eventually affect the patient and family experience, but ultimately changes society's experience. And this is part of what I think we need to understand, that end-of-life care, hospice, however you want to call it, goes beyond the medical health aspects. It goes into it is the public health in the larger sense. Where do people live, and who do they have to call their family, and what is their religious context, and their conditions, and their financing, and their everything about them. So in our change for individuals, that's what we would look for. And then that same applies to organizations. And interesting enough, you'd never think of sort of the two things, but we want to change the attitudes within organizations. And I work in an organization where I really want to change the attitude, and that's very much my business. We want to change the knowledge, we want to change the skills, we want to change the behaviors, we want to change the organizational experience. And we do want to change society's experience as well. So these are the principal activities then. When you come to what we'll be coming to momentarily, it's a square of care. It can be broken out into these domains, and it helps to sort of understand where activities fall, how you might want to break out some of your stuff. And here we go again. In this particular thought and focus on the model, we have Pallium in every jurisdiction. I leave out management and administration because that is really part of what makes Pallium go. So there's our square of care, and this is probably the most informative piece of the model if you want to think of how it tries to direct practice and program support. We looked at the domains of what it is that patients and families deal with in the care experience. What is the process and the things that are necessary to make the process work for them? What are the program supports that are necessary to put in place, from funding down to research? And the governance and administration aspects that make the whole thing come together. Because without the leadership and the governance, this can be quite wonky. So this integrates this around the patient and family. And again, because Pallium does touch on many aspects, I started to map out, well, where does that go? Certainly the process of providing care. That's very much what your first phase. Your first phase was focused on, and the patient and family care experience of improving that. Now what you're working into, though, is things like the planning and advocacy. What you're working into is how do you change the funding models? How can you look at how it is to influence the policy and the decision makers? Certainly the education has always been there, but then more with a focus on the evidence base and the research. How can you catalyze the research so that you can get people moving into the area of the science of palliative care? But within the square of care then, we have the patient and family, patient and care, process of providing care, governance and administration, program support, education, and there's where I really see the biggest bang for the buck for Pallium, is when you put it underneath education and support that. That's what will drive the whole model for it. The domains that we look at, the disease, physical, psychological, social, spiritual, practical, loss, and death management, are areas around which we can look at how we structure some of our education. These are the domains that we agreed upon as being absolutely essential and core to good hospice palliative care. The process, again, is assessment, information sharing. There's a big piece around kind of work that Michael's doing in terms of surveillance that we don't do well. How we aid patients and families in decision making, and not just in the moment of saying, am I palliative, but long before that to say, what are the choices I'd like to be able to make if I have health choices in front of me? Actions. And this is part that again, for my interest in the cancer world, is some of the interventions that we have aren't so terribly therapeutic, and how do we balance and weigh off when we're doing benefit and when we're doing harm, and the processes that we have. This is a nasty slide, but it does show listing out sort of all the elements that the model does specify that need to be in place for financial, human, information, physical, and community resources. And again, I think Pallium tends to sit in the financial resources in the sense that it's going to catalyze a lot of activities with some funding for us all, some information resources, and the community resources in strengthening that. And then the basic functions, again, the governance at that other square that we had with the planning, operations, quality management, and marketing, there's where Pallium sits for those areas as well. So what the norms do say, though, is that we also have these levels of expertise and competency that we need to look at. And the other piece about it is that there is this notion that we went to norms so that we wouldn't be talking about one standard that fits all. Because it is actually the rural experience, the underserviced populations who said, you can't give us a standard that we're going to have an interdisciplinary consultative team. It'll make us nuts to try to get it, and you know what, we really don't need it. And so having that sense of what's necessary that fits for a community is really where the norms wanted to provide support. And they did say that there was a notion of a primary provider, a secondary expert, sorry, went out of the box, and the tertiary expert, and that these are all valid places of expertise that we want to support and that we want to ensure are there for access to quality hospice palliative care, and that we need to have the resources in place to do it, which Pallium does very nicely and will do very nicely, particularly. So my summary statement is really that Pallium not only fits with, but actually brings to life the ideas embodied in the CHPCA norms. It isn't a matter of what do we have to do to tweak it and make it look good. It's really going to push some of those elements out that up until now have been words in documentation and not actually had a living, breathing life.